Professor Jean-Marie Parel from Miami, and the title is Latest Update on In Vivo Measurement Methods of the Accommodation in Humans, Consequences and Impacts on the IOL Conception and Design.
This is my team, and they all wanted to come here, of course, when they heard it was in Paris. So, what you are going to see comes from these young people. The University of Miami insists for me to actually write that, to which I add that the University of Miami owns my soul, as well as the patent and everything else. I also have to acknowledge our support from the government, including the Australian government, and the fact that a lot of people have helped from different countries, different universities. And the title is a little different. I was trained by surgeons like Jerry Kroc, Franz von Kauser, Philippe Saudy, Didier Ducournau, and I'm always thinking of the patient when we do research, and so are these young people listed there. What I would like to talk about today is the restoration of true accommodation. And I will go through accommodative intraocular lens, lens refilling, the anti-PCO war, a three-dimension UBM to assess accommodation morphology, real-time SDO-CT, also in three dimension, the world impact and regulatory affair, and a timeline. Now, we all know that when you are approximately 50 years of age, your brain is working very well, your ciliary muscle is working also, the zonules are perfectly healthy, the lens capsule is extremely elastic, it does not change with time, certainly not in the first 50 years of age, but that the problem is the lens keeps on growing in the very same capsule. So it becomes fuller and fuller and fuller and can no longer expand, and it becomes harder inside. As all of you who do cataract surgery know, when the patient is getting older, you got to use phaco. You can no longer do a simple aspiration of the nucleus. Restoration of accommodation has been attempted many years ago, and Tsutomu Hara, who is a friend of Dr. Saudy and myself, actually came up with this idea of double optics, accommodative intraocular lenses. Today's status in the United States of America is crystallines, and at best, as the group in Vienna has demonstrated, we might, if we're lucky, get one diopter of accommodation. The second lens that is getting FDA approved is a Synchrony that's 2.2 diopter of accommodation. The problem is that if we don't control PCO, it will annihilate, kill if you prefer, the restored accommodation, as can be seen here in a Miyake picture, and much better on a patient. And you can see, in fact, the two masses of de novo tissue that actually grew so big that it tilted the intraocular lens. We got the same problem when we do lens refilling surgery, even though, and I'm sure you all know about that one, so I can go forward. Even though we are getting a lot better or more accommodation, 10.6 diopter versus 14.6 in this monkey. And that was confirmed a few years ago by Pharmacia, which now became AMO. However, when you do the surgery, you have the very same problem, meaning if you follow your patient, you are going to have PCO. In the rabbit, it's extremely fast. In the monkey, it's like in a child and not like a 50-year-old person. So if you think about the demographic and what's going to happen, today, 20,000 cataracts have been removed every day. That means 20,000 potential cases of PCO every day. And of course, you can do capsulotomy, YAG, but you do have complication. It does cost money, and it prevents restoration of accommodation. How do we assess this in patient was the objective, because we are 9 months from getting into the patient with lens refilling. Do we use OCT? Well, we can't see beneath the iris with OCT. Is ultrasound biomicroscopy good enough? Stack demonstrated that you could look beneath the muscle. So we bought such a machine thanks to the government. We actually did some testing on cadaver eye, which are on a stretching mechanism. We were able to find, number one, the speed of sound is not constant in the human eye, in the human lens, and in fact it changes while you stretch. And it corresponds, in fact, to the same profile that the refractive index has in the lens. Now that might be kind of obscure for you if you are a surgeon, but in fact it's very important because it indicates the parameters you need for your intraocular lens or for the polymer that will be injected. So we started to do lens shape quantification, came up with mathematical model to actually describe what's happening with time, with age. And here we have a model that goes from 20 to 80 years of age, which definitively shows, and this is based on human eyes, definitively shows that the volume of the lens keeps on increasing with age. It also shows you the volume of the lens you had at age 16 or 20. By doing measurements at age 50, we can deduce what you had at age 20, which means it actually gives you the amount of material you can actually put in the lens to be able to restore accommodation. Now, how do we simulate that? We can, of course, not do this on a live human being, but we can do it on fresh cadaver eyes with a machine that actually measure the forces that are applied to the crystalline lens. And we can connect the 3-dimension UBM probe and demonstrate what's happening not only on the lens, but also to the ciliary body. And we can do this real time. Now, we can actually do a total integration of what we have done, what the machine has done, and we create 2 different sections. In other words, a section parallel to the equator of the lens or a section perpendicular to the lens. This actually is a probe that we now have that is applied to the eye for peri-operative analysis, meaning pre-op, so that you can see what lens you're going to have, and post-op to see actually the evolution of the lens, if you have an intraocular lens, accommodative intraocular lens, or lens refilling. And we also have an OCT system mounted on the same system, so we can compare both UBM and OCT image, which means what we can actually deduce from the math the radius of curvature with very high precision, then put this into a finite element model and being able to predict mathematically what a lens will do in a human being before you do the implantation. And that's not really addressing what's happening intraoperatively. And the goal, this is a normal lens, 16 years of age. This would be a refill lens. The surgeon really would like to see this while he does the surgery in 3 dimensions. And this we have started to do. This is a 3-dimensional model of a human lens that's ex vivo. As you can see, you can actually go through the whole lens and the ciliary body. You can now have a 34-year-old patient. This one is one of the, in fact, is one of the inventor of that machine. Look at the whole lens, including the, anterior segment. Look at anterior and posterior capsule and look at the detail. And you can actually do this on a 60-year-old, yours truly, and look at his lens and compare it to a 30-year-old lens. And you can do this real time. And this can be integrated in 3 dimension so that you get this. So this is actually a patient, the same young man, where we can actually look at the volumetric and the characteristic of the lens in 3 dimension. Or you can look at the entire anterior segment, cornea to the posterior part of the lens. I'm sorry, it's very fast. And actually deduce all the biometry of this eye. Now we look at the practical approach, right? We have 60 million cataract today, which is $1 trillion. A lot of money. Imagine now that all of the 50-year-old will want to have an accommodative intraocular lens or lens refilling. We have 1 billion presbyope, which means $50 billion or trillion or whatever. What we need is pharmaceutics, and I hope CROMA will be working on that, to slow or stop lens epithelium growth, the perioperative 3D UBM to determine pre-op volume and monitor AOL plus shift and PCO, and an intraoperative OCT. Now, we have already tested and we have now the ideal polymer that has the right index of refraction, viscosity for injection, as well the elastic modulus to be put in the bag, the intraoperative SDOCT and autorefractor. You will want to have this on your operation microscope so that by the time you finish the case, before you suture the eye, with the patient lined up on your table, you will be able to check that what you have done is correct and that the patient is going to be emmetrope. We plan to do the first patient for what is the phaco ersatz patient's concern this Christmas, in December in other words. Perioperative 3D UBM will be ready by the spring. And Dr. Culbertson is already using a femtosecond OCT to help him doing 2 things. Photoliquefy the nucleus and cortex, although that's not really necessary, and also to do a perfect capsular axis. I hope anti-PCO war will be won by 2013, because otherwise I will not see it. And I don't know what's going to happen with the regulatory and phase 1. If you are interested in the biomechanics, optobiomechanics of the lens, you're all invited at Bascom Palmer in the Friday after the ARVO meeting in 212. Thank you very much.
Thank you very much. Are there any questions for Professor Parel? I have a question. Do you see any advantage in going to other wavelengths in OCT to monitor this?
Yes, but for what is the accuracy of assessing the lens curvature, we need a short wavelength and a wide, a source that has a very wide, like 100 nanometer bandwidth. And that's not available at 1.3 micron.
Okay, thank you very much. So I would now like to close the symposium. Once again, thank CROMA for sponsoring it, and I wish you a nice afternoon.